Hello, my name is Amanda Sturgeon, and this is my lecture presentation on vision screening process for New Mexico Public Schools. This is the outline my presentation will follow, and by the end of this presentation, you should be able to identify who needs a vision screening, what ages, what types of screening are required, and any changes made in the screening process for COVID. So why do we do vision screenings in schools? Vision problems in children are common and if left untreated can lead to permanent disabilities and vision loss. Vision impairments can lead to behavioral problems and literacy problems. It helps identify children with possible eye diseases and get them a referral to a specialist. It can identify amblyopia, which if not treated by ages 6 or 7 can lead to permanent vision loss in the affected eye. And it's also an opportunity to educate on eye health and hygiene. Some of the key terms that we should know: strabismus, what we call cross-eyed, a condition where the eyes do not look at the same place at the same time, usually from a lack of muscle control, cannot be prevented but treated if caught early. Amblyopia, lazy eye, the result of untreated strabismus, reduced vision in one eye. Myopia is our term for nearsightedness. Hyperopia, our term for farsightedness. And this is how we chart a right eye, oculus dexter, OD, or oculus sinister, OS, left eye, or OU, oculus interque oculi unitus, or both eyes. And a trick to remembering the difference, OS for left eye has an S in it, and southpaws are lefties. Astigmatism, irregular curvature of the cornea or lens, which results in a distorted image, affects vision at all distances. It's corrected with glasses or contact lenses. Color blindness, an inherited vision defect, usually the inability to see red or green, but rarely can be blue or yellow. It's not correctable, but if we identify it, we can help with coping skills. Anisometropia, unequal refraction of the two eyes, common cause of amblyopia. Legally blind, their acuity is 2200 or worse with best possible correction. And cortically blind, the visual system is intact, but there's brain damage, and it prevents the brain from processing the visual image. So who needs a vision screening? In New Mexico, we screen pre-K students, usually age 3 to 4, kindergarten students, age 5, first grade, ages 6 and 7, and third grade, ages 8 and 9. We also screen new students or if anyone's had a deficit noted. We must notify parents when screenings will take place so that they can opt their student out. Students that are referred by the SAT teams or student assistance team or special education teachers, they get the general vision screening plus a near vision screening. If a student fails any of the screenings, then we will retest in 2 weeks. If they fail that test, then we need to send a notice home that they should see a specialist or their primary care physician. The types of screenings that we do a pre-screening assessment and make note of any visual behavior observations. We test visual acuity, distance visual acuity, ocular alignment, near vision acuity, and color vision. Some of the visual behavior observations that we watch for, or we have the teachers watch for as well, is students that are visually inattentive or uninterested, have difficulty maintaining eye contact, hold the objects close to their face, tilt their head, seem to be sensitive to lights or sunlight, tend to bump into things, trip over objects, maybe stare at the lights or ceiling fans. The pre-screening assessment or the exam, we examine the eyes and look for cloudy or a milky appearance. A keyhole pupil, which is called a coloboma, an irregularly shaped pupil from tissue that has grown irregularly. It's rare but can lead to vision problems. A sustained eye turned in or outward. Droopy eyelids, ptosis, if the eyes are not moving together, if there's any abnormal pupil constriction or dilation, if there's a difference in size or shape, excessive tearing, or if there's any nystagmus noted, or the repetitive irregular movements. These are the approved testing charts as recommended by the National Center for Children's Vision and Eye Health to measure distance acuity. Charts will specify if they're to be measured at 10 feet or 20 feet. The distance is from the chart to the child's eye. We test one eye at a time. These LEA symbols, this is this first chart here. It's good for students ages 3 to 5 or those that cannot read the alphabet. It's used with a key, so they'll hold some cards to point to match with what the symbol is on the chart. 3-year-olds, 2050 would be referred. 4 to 5-year-olds, passing is 2040. We would refer if either eye is 2050 or above, or if more than one line difference between the eyes. HVOT, that's this second chart here. And Sloan, it's good for 6 and above, or those that can read the alphabet. Passing is 2032. We would refer if their score is 2040 or above. These are the accepted charts. There's a specific distance between the symbols, and the inverted triangle is specific to these charts. Unapproved charts to measure distance acuity: the tumbling ease, the Snellen, which is what we use in nursing school and in the hospital in the emergency room. It's okay for general screenings of adults, but we don't want to use them in elementary schools to test students. Or random object charts, boats, hearts, stars, things like that. These are some of the occluders that we use for ages 3 to 10. We can use these adhesive patches. We can use 2-inch wide surgical tape or occluder glasses, which is the best recommended. Or for students 10 and above, we can use the Mardi Gras mask or lollipop occluders. One of the tests for ocular alignment and tests depth perception is the stereo acuity test, a random dot E. It uses polarized glasses to see if the student can identify the object in one of the slides or the plates. There's also butterflies or flies that can be identified depending on the test. It detects binocular abnormalities, can be used on children ages 3 plus, and we tilt the cards back slightly just to ensure that there's no glare. Another test we can use to check ocular alignment is the Hershberg test. This looks for equal corneal light reflex in each eye to see if the eyes are aligned equally or in the same position. So we shine a pen light 50 centimeters from the eyes and have the students look at the light. You can see the reflection in both the pupils is in the same place. Some abnormal results. You would see the reflection on the outside. For esotropia, the eye is turned in. Exotropia, the eye is turned out. Hypertropia, the eye is turned upward. And Hypotropia, the eyes turn downward and the reflection is at the top. We can also use instrument-based screenings for checking ocular alignment, photo screeners. It's a quick and easy way to check ages pre-K through first grade, or for those that cannot participate in other screenings. It uses the lights and sounds to attract the student's attention. It takes less than 3 seconds. We must hold the machine about 3 feet from the student, so proper PPE is needed. These do not measure visual acuity, but it does give an estimate of refractive error using the red reflex to test for ocular alignment. And these are examples of 2 of the vision photo screeners. Near vision acuity, it's not required for mass screenings, only for special education referrals. Comes with a 16-inch cord that's attached, and you put the cord next to the student's temple to keep the distance an exact 16 inches. We can use Leah symbols, HOTV, or Sloan letters, depending on their age. We test with both eyes open, and they must identify 80% of the letters on the critical line of 20/30 to pass. Near vision acuity testing is not always accurate in students ages 10 or less, but it might help identify astigmatism if the symbols are blurry. Color blindness screening. This is required only once in any target grade. Most colorblind screenings are done with the Ishihara book with pseudochromatic plates. It's a set of colored dots, plates, that have a number or a path that the child must identify or follow. It's the most widely used color vision test. Dr. Shinobu Ishihara created it in 1917. Nurses usually have to have their color blindness checked in the hospital so that we can properly assess hemoccult and gastrocult results, as well as any equipment that is color-coded. Some of the COVID considerations for vision screenings. We want to prioritize screenings for students that have never had a screening done or that demonstrate need. If possible, we want to screen in a large, open, well-ventilated space or even outdoors. We must maintain or try to maintain 6 feet between the screener and child. If that's not possible, we want to make sure adequate PPE is used, including masks, shields, gowns, and gloves. We want to ensure the student has a properly fitting mask. We need to document students for contact tracing purposes. Ensure that both screener and student wash his hands before and after. We need to disinfect the equipment and frequently touch surfaces in between each student. If possible, we would like to utilize disposable supplies. And if we need to, we would postpone color screenings and ocular alignment in younger students, depending on the COVID numbers in your area. Just to recap, important to screen the students that are new and to try to help identify vision problems before they impact their learning and behavior. Use proper PPE, ventilation, and distance. Screenings can include distance visual acuity, ocular alignment with stereo acuity tests, photo screeners, Hershberg Test, near vision acuity, and color vision. And we would want to rescreen any student 2 weeks after and then send a notice home with the student if they don't pass. And these are my references. Thanks so much.